So since Dylan, our 5-year-old middle child, was a baby, we knew something wasn't quite right. Our concerns were that he couldn't go up the stairs very quickly, and he couldn't. He had a speech delay. The doctors told us that he had low muscle tone, and physical therapy would help. I worried, like lint on a sweater. I could not remove the feeling that something was wrong. And after 2 years of physical therapy, he didn't improve. And so a year and a half ago, we finally demanded a diagnosis. And to everyone's shock and horror, Dylan has Duchenne muscular dystrophy. Muscular dystrophy is a muscle wasting disease, and Duchenne is a lethal form of the disorder. Steroids will slow down the rate of progression, but unfortunately at this time there's no effective treatment and no cure. It affects boys primarily because it is usually inherited from the mother's X chromosome. However, a third of the cases are de novo, a genetic fluke. Like in our case, there's no family history. We were shocked that in a place like New York City, it took us years to get the diagnosis. Duchenne affects all races and cultures. Approximately 12,000 patients in the U.S. are living with Duchenne, and now so is Dylan. And as they say, it couldn't have happened to a nicer, sweeter kid. He tolerates it so well. People always say it's harder on the parents than it is on the kids, but I would change places with him in a nanosecond. Duchenne originates from a gene that fails to produce dystrophin, a protein that helps muscles stretch and contract normally. Patients are usually using a wheelchair by age 12, and as the disease progresses, the muscles in the heart and pulmonary system are affected, leading to death from respiratory or heart failure. They usually die in their 20s. Duchenne is extraordinarily complex. From a scientific point of view, it is perhaps fascinating. From my point of view, it is heartbreaking. Dystrophin affects every muscle in the body, and no one approach is likely to be a magic bullet. It's going to take a combined approach to stave off the degeneration. The one thing that all Duchenne families will say is that it's a race against the clock. The boys only have a certain amount of time before they lose ambulation, before they require a respirator, and before they die. Dylan is one of the luckiest of the unlucky with a mild phenotype of the disease. There are experimental drugs that may work with Dylan's specific premature stop type of mutation. A drug called Adelorin may provide benefit for Dylan. PTC's Adelorin has been reported by the company to have an excellent safety record. However, the drug company failed to achieve a high enough p-value to prove statistical efficacy. Dylan would be an ideal candidate to start the drug, so we anxiously wait as it goes through the regulatory process. While no one can or should ask the FDA to lower their safety and efficacy standards when approving a new drug, we can, as a rare disease community, ask them to be flexible. Rare and ultra-rare diseases aren't demanding a miracle in a pill. We simply ask for treatments with small, measurable outcomes that aren't captured in time tests. We need to engage the FDA to look at a range of things to be used to confirm a treatment effect, but still capture the need for safety. Patient-reported outcome measures could be the answer for better capturing the data in a trial. Using something like a composite score could provide more accurate outcome measures. A collaborative endpoint initiative for measurability is needed, and training FDA regulators on the unique aspects of muscular dystrophy and rare diseases is needed to provide greater flexibility in the threshold for approval. Progression-free survival should be enough. Patient and parent groups have are proven advocates for translational research. They can motivate and they can get money, but no amount of translational research means anything if a drug cannot be approved. Rare diseases are having more and more drugs coming down the pipeline, and it's essential to ensure that patients get them as soon as possible, especially in the absence of any other treatment. The Duchenne community is a condemned population. We have a 100% death rate by 30 years old. We are willing to take on some risk to buy a few moments here and there. When you have a child with Duchenne, the death sentence of the diagnosis hangs over you. And while I have never experienced death row, it feels like our sons are locked in that prison. Whenever Dylan talks about what he wants to be when he grows up, tears come to my eyes. What will I say? What can I say? What would you say? It's difficult to explain what that does to a parent. I can only speak for myself, but the realization that life is so fragile greets me each morning and accompanies me to bed every night. I've learned to be grateful for the bounty of life and what this child teaches me. My hope is that Dylan will have access to his life. This is a child who loves to learn, who has an imagination and great sense of humor. He may want to be a lawyer or a video game designer or study anthropology at college. He may want to get married and have children and to make money, and as much as it annoys all of us, to pay taxes. Our deepest hope is that Dylan will realize all of his potential and that he will be able to say he fully lived and gave.